Hey folks, it's George Kovac here, and we're going to talk awake intubation in the emergency department. Now, this is the second post on this subject matter. The first one was called Sleepless in Halifax, and you can view that on aimairway.ca, and I'll get back to that in a minute. Now, awake intubation in the emergency department, even though we talk about it, it's something that I think historically has been done quite rarely, and I'll address this issue. We've been big proponents of it here in Halifax, and part of our teaching, our airway program over the years. And it's a hard thing to get experience in for sure. Now, I do have to say that I don't think that there are many people on the universe that have had their larynx looked at as much as I have, both by myself, doing selfie scopes and then selfie intubations, but by others. And I'm not sure if I should be proud of this or whether it's a sign of something else. But I do have a reasonable amount of experience. It's hard to become an expert on the subject in emergency medicine. But part of the premise here on this post is that I think it's an underused technique that we should be using more often to manage certain cases. If you've heard me talk on the subject of psychology of airway management, you've heard me talk about the fact that most normal individuals who take care of sick patients are still somewhat fearful of the difficult airway. And this is a natural thing. Regardless of what our veneer is that we show, most of us will be anxious about managing the difficult airway, at least when we anticipate difficulty. Now, I've had the great fortune geographically of living in a beautiful province in Canada, Nova Scotia, and living in the city of Halifax. And it's been I think, a hotbed of for airway educators and hanging out with people like Mike Murphy and Orlando Hung, who are from Halifax, and Adam Law, who is my colleague and co-director of AIM, and Ian Morris, who most of you hopefully have had the opportunity to meet in my first post on this subject matter, who happens to be a neighbor who lives just 3 doors down. As I said, he's the previous author of the airway chapter in Rosen, at least when I was a resident a few years ago, and I really think he's written the definitive chapter on the subject in Mike and Orlando's book on the difficult airway. So having the opportunity to hang out with these people who do a lot of awake intubations has given me the opportunity to learn from, I think, the best. Both Ian and Adam were involved in publishing this series of over 1,500 awake intubations with a first pass success rate of over 93%. The issue comes up, though, is how does that apply to managing the patient awake in the emergency department? Now, this is a picture that I took one day in our department. There are 2 cases coming in within about 15 minutes of each other. And the first one was a 38-year-old self-inflicted gunshot wound to the face who wasn't tubed. And the second one was a 55-year-old morbidly obese patient coming in as part of a post-hanging. Now, again, I think most of us, when we look at the board and see what's coming in, we'd be a bit concerned, as they both represent potentially difficult airways. Now, what does the difficult airway mean? I think most would appreciate that it's either difficult laryngoscopy, difficult intubation, difficult mask ventilation, difficult supraglottic airway ventilation, and or difficult front of neck airway access or surgical airway. And there are various acronyms out there to help us identify prospectively the difficult airway, which don't work very well, and all kinds of algorithms that various organizations and individuals have proposed. The Canadians aren't any different with Canadian Airway Focus Group, which I had the privilege of being part of, which is mostly made up of anesthetists, published the approach for both the anticipated and unanticipated difficult airway. So what we're trying to anticipate or predict is difficulty, and simply put, is the patient going to be tough to tube, bag, or ultimately rescue by using a supraglottic airway or ultimately a surgical approach? The problem with prediction is that we're not very good at it, and upwards of 90% of difficult airways are unanticipated. But I think in emergency medicine, this has produced a scenario that I referred to in the past as Hamlet's difficult airway paradox, to be awake or to be asleep. And I'm not an expert on Shakespeare. It's the only soliloquy that I had to memorize way back in high school a few years ago. But the issue is this, is that ultimately what we're trying to do when we predict difficulty is to help us make a decision of whether we should put the patient asleep, whether it's safe to do so, or to have them maintain their respirations during the intubation process. So essentially doing an RSI versus doing the patient awake. The challenge is this, when you think about it, okay, most of us in emergency medicine are comfortable in doing rapid sequence intubations, and I'd suggest that that's what we do 95 to 98% of the time, if not more than that in some institutions. So then we identify somebody that's difficult, and if you follow these various algorithms, it suggests, well, we should do an awake approach. Well, now we're supposed to do an approach that we don't do very often that's technically more difficult in a patient that is a difficult airway. So there is the paradox of the scenario, and is that the safest route to go? I don't think it is if you don't have experience and expertise in doing this. But again, is it less safe than doing an RSI in somebody that has identified difficulty? I don't know the answer to that. Now, let's recognize that there really are two types of difficulty. There's the one that, you're in Walmart and you're looking at that patient or looking at a person at the checkout counter, and you're looking at their morphology of their face and you say, wow, that person would be a difficult airway. So anatomically, they're difficult. Versus the patient who's got an arrow through their neck or whatever it is, where it's quite easy to identify that this is a potentially difficult airway and has a high likelihood of being so. So those are two different scenarios: the anatomically difficult airway or the pathologically difficult airway. The other group that's been more recently recognized is the patient with difficult physiology, and there's a great summary on this subject by Mosier and others, the physiologic difficult airway, and describing 4 different phenotypes of the physiologic difficult airway. But the most common one that we encounter is the hypoxemic patient, and the patient who is not going to be able to tolerate apnea. And we're not going to be able to adequately pre-oxygenate the patient to have a safe apneic period. And this is the patient that I'm doing awakes on more often. So the difficult airway really is expanded from difficult anatomy and pathology to difficult anatomy, pathology, and physiology. And this is the group where I think we should be doing more awakes. It helps us develop our skills. It's probably the safer route to go. And then we've had that skill that we can use on the patient that presents with difficult anatomy or pathology. The problem has been historically, once we identify the patient as being difficult, whether it's anatomy, pathology, or physiology, we have to make a judgment of whether we're going to be able to do an awake approach, because the patient really has to have some level of cooperation to do this successfully. And this is where in emergency medicine we tend to abandon it. We say, yes, we identify the patient as difficult. Let's see if they're going to be cooperative, and we look at them, and for reasons of altered level of consciousness or agitation or some other reason, we say, no, we're not going to be able to do it, so we justify doing an RSI in this patient. So this has changed for me significantly over the past number of years, and I've moved from very rarely doing awakes to doing them quite commonly. And I'll use some examples here. I've done awakes on, this gunshot wound to face. I did an awake, on this patient, and I'll tell you how you can do it in that scenario where there's blood and potentially in the airway. And I used a nasal approach and using the endotracheal tube as a guard for your scope. But that's a bit too specific, and I'll talk to you a little bit more about that. But the awake, really is about proper topicalization, and that's what you need to be successful in doing the awake approach. And you need the patient who is cooperative to do so successfully. Sometimes we need to facilitate cooperation, and that can be done with an agent such as ketamine, which I think is the preferred drug to use. But I don't routinely use it. And you'd be surprised at these sick patients who you might write off as being uncooperative, who will let you topicalize them in a way that is just as good as a controlled situation in the operating room. So first, before we get on any further on the subject, I want to talk about what the heck is an awake intubation. So my definition is this, is that it's intubation performed on a patient with preserved spontaneous respiration, and it's facilitated by the application of topical anesthetics. What is not an awake intubation is intubation performed on a patient with preserved spontaneous respirations, facilitated primarily by the use of sedatives. This is the old-fashioned deep sedation, and I'm definitely not condoning that we go back and do that. If you look at the data from NAP4, one of the reasons that was listed as a cause for failed awake approach was the over sedation during the procedure. Now, a term that I don't like that's out there is KFI, or ketamine facilitated intubation. And I know there are several jurisdictions here in Canada that are looking at in the pre-hospital setting using ketamine to facilitate intubation, trying to get away from the benzo narcotic route of a medication-facilitated intubation, thinking ketamine might be the better agent. Now, ketamine's a great drug, and it probably is better than these other drugs. But there's no evidence that I'm aware of supporting the use of ketamine alone to facilitate intubation. And the only series that I know that published on this, again, it was a pre-hospital study, but pre-hospital with experienced providers, and the first pass success rate was just over 50%. Maybe ketamine's okay alone. I don't know. My experience is no, it does not provide optimal conditions, and it is not an awake approach. So let's talk specifics in terms of preparation. Ian, in my interview with him, routinely uses a drying agent, so uses glycopyrrolate, and he gives it intramuscularly, he gives it 30 minutes before. Some people use it intravenously, and if you give it 15 minutes before, it'll give you optimal drying conditions if you wait that long. Now, even though we usually have some time to do the awake, I can't say that it's very often that I have 15 or 30 minutes before I can really start the topicalization procedure for my patients. And this is just me. I haven't been using a drying agent, and it's gonna dry up the tongue, but it's really not gonna influence pathologic secretions of a sick patient with pneumonia or respiratory failure that we're managing. But again, I'm just saying that on my awakes, I haven't been using a drying agent. I'm not saying don't use it. I'm just saying I haven't been using it. Now let's get down to topicalization. Let's dispel one, I think, myth is that you really are not going to get optimal conditions by aerosolizing your lidocaine. So by putting 5 cc's in, a nebulizer and nebulizing lidocaine, most of it ends up either in the air or in the lower airway. And we need it to be applied to the upper airway. Now, I've tried this on myself, and some people have suggested that if you use it at low flows, you get somewhat of an atomized effect. The problem is it takes a long time to administer it. And again, I've tried this, and it has not been successful. And as I said, I've had a lot of topicalization done over the years and a lot of laryngoscopy, and I would never do this as a primary approach. To do this, you need to get the gear. And what I mean by getting the gear is you need to use the appropriate drugs. And there's only one drug that you're going to use here, and that's lidocaine. And using lidocaine, 4% aqueous solution, and then using an ointment, a 5% ointment, that's the way to go, and I'll talk about that in a minute. 4% aqueous should be available anywhere. Some people suggest, diluting it to create a 3% by mixing 2% and 4%, or diluting the 4% with some water. I haven't been doing that. The problem that many people have, I guess, in the U.S. is getting access to the lidocaine ointment. It is available. It is expensive. And as I understand, it's not reusable. So what we do is we just have the ointment. We apply it to the end of a tongue depressor and then use it in the mouth. And I'll talk about that in a minute. And then keep it stored on our airway cart and use it on the next patient. So I guess this is frowned upon in many U.S. hospitals and precludes its use. But I'm sure there's ways to problem solve that by getting your pharmacy involved and seeing if they can create some individual doses of this drug. But it is, I think, critical for being successful in doing awakes. Now, the next important thing about getting the appropriate gear is having an appropriate delivery system. And the one that we use is this easy spray disposable atomizer. It costs about 20 or 25 bucks. Comes in 2 volumes. I think the one we use is a 15 mil one. There's really no need to get the larger one. And you're going to use about 8 to 10 mils of the 4% in this. And you hook it up to oxygen or medical air at about 8 liters per minute, and it's got a directional tip, and it atomizes your lidocaine. And it's a great device, and I'll include some information in terms of how you acquire it. So let's go over the procedure, how I do it in the emergency department. If the patient is reasonably cooperative, then I'll give them the suction to hold in their hand, and they can use it to apply as they feel necessary. I think it's important that you talk to your patient, explain what's going on. You should warn them that when their airway is topicalized, there's this phenomena of lidocaine dyspnea. I don't know if that's a term, but I'll use it to describe what they experience. But when their airways anesthetize, you can get a sense of dyspnea. And I think what's happening is normally when you're breathing, that you sense subconsciously the flow of air as you take a breath. And you lose that when your airways topicalize. And that can give this subjective sense of you're not getting appropriate breaths. and can cause some anxiety. So explain to the patient that they're going to be fine during this. They might cough. This is sometimes unavoidable, but you can warn them that that's something that might happen. Now, I tell the patient that this is going to taste terrible. There are some flavored lidocaines around there. They're more expensive. I've never used them. It's just a bit of a nasty reality. So the next thing that I do is I take the atomizer, the easy spray with the 4% lidocaine that I will put about 10 cc's in there, and I'll deliver it to everything in sight orally. So tonsillar pillars, soft palate, back of the tongue, posterior pharyngeal wall, and that's it. It's sort of one reasonably quick administration. They're going to swallow whatever's there or suction out any excess. The next thing is critical, and this is the application of the 5% ointment. So we'll take about a centimeter or a centimeter and a half of lidocaine 5% ointment, put it on a tongue depressor, create this sort of lidocaine lollipop. And then what I do is I get somebody with a gauze who's going to trap the patient's tongue. So our patients usually aren't able to keep their tongue out, but they grab the tip of their tongue with a gauze. Somebody's holding on to that, and then you're gently applying the ointment to the posterior aspect of the tongue, not to the front of the tongue, the posterior aspect of the tongue, so that the lidocaine ointment is going to melt and fall posteriorly to the region that is most sensitive to gag when you instrument that region. So I'm not wiping it off on the back of the tongue. I'm just using the weight of the tongue depressor and going from left to right and letting it sort of melt and fall back. You might have to give them a little bit of a break. They can swallow and do whatever. And it might take 2 or 3 applications to deliver this initial dose of the lidocaine ointment. I've done this, I said, on some very sick people, and it's usually well tolerated. But this is the critical piece, to have them tolerate instrumentation as part of doing an awake intubation. Usually do one application of this. There are some patients that require a second one, recognizing that there are variable gag responses that are out there, but usually one is enough to do. The next thing to do is to try to topicalize the airway, because we really haven't done that. Up to this point, you can probably do laryngoscopy if you're doing it with each other, but you're not going to be able to intubate the patient at this stage. So 2 ways to do this. If the patient is cooperative and they can take a breath on command, then we're going to do it nasally, because the nasal approach is easy access to the airway. So during inspiration through the nose, you're going to deliver your atomizer, and you're going to do this on 3 separate occasions. Them taking a big breath in through their nose, and then you delivering your 4% lidocaine on 3 separate occasions. If your patient isn't cooperative and they're unable to take a coordinated breath, then you do this through the mouth. And again, you get somebody to trap the tongue. Again, the easy spray has a directional tip, the nozzle. You bend it down to 90 degrees, or somewhere between 75 and 90 degrees, and then you spray. If they are not able to take a good breath with that, this is when they're potentially going to cough. So be aware of that. Also be aware of the fact that it's a known phenomena that patients have obstructed, particularly if they have perilaryngeal pathology, to this at this stage when you administer a topical to the larynx. So at all times when you're doing this, you need to be prepared to manage a definitive airway. Just a quick reminder of that fact. So again, with the uncooperative person, you're going to do an oral approach to topicalizing the airway. With a patient who is cooperative, more cooperative, you're going to do a nasal approach. So let's talk toxicity. And I think there's a fair bit of misinformation on this subject. Just to summarize what I'm using between 8 and 10 cc's of 4% aqueous, and then about 1 to 2 cc's of 5% ointment. And this is what they've been using here in Halifax for over 10 years, and have had no toxicity that we're aware of using this dosage regime. Now, what about absorption here? This is clearly more than 4 milligrams per kilogram in most patients. And that's the recommended, max dose that some people have suggested. And that's based on data extrapolated from when we inject lidocaine for, doing various invasive procedures. But atomized lidocaine, the absorption of that is going to be nothing equivalent to what you're going to get when you use it by injection, or you use a more viscous type of agent. And particularly in situations where I'm not using a drying agent, there's an additional dilutional factor that's happening with the secretions that are there. I'm not condoning that as a method of diluting your lidocaine, but it's just a fact of life of something that happens. Now, the British Thoracic Society apparently lists 8 milligrams per kilogram as the upper limit that they recommend using for bronchoscopy. Now you can, as I said before, you can dilute 4% to create a 3% solution by mixing with either some 2% or diluting it with water if you feel that you're approaching a toxic dose. But again, if you look at the evidence, and I think Ian Morris's chapter on this in particular, his revised chapter, which will be out by the fall of 2017, where he's got over 300 references on this subject, is a great document for referencing this toxicity, and I don't think we need to be concerned. You have to balance what's the risk of something bad happening, such as a seizure, versus the benefit of having a well topicalized airway that's going to facilitate you intubating a patient who's sick and needs this as the procedure of choice. So again, I think we can safely use these doses, and I can address this on a separate post or with some Q&A at a different time. Now, with the uncooperative patient, as I've said, one of the things that you need to do is alter your delivery mechanism. So you're going to have to use an oral approach as opposed to a nasal approach. But the other thing you can do is when you're going to scope the patient is approach it through the nose. And if you're going to topicalize the nose, again, you're using your atomizer through the nose. I also put some ointment on, or you can use in this situation some jelly. I put it on my baby finger, and I dilate the nair that I'm going to use, usually the right nair, with my baby finger. It has lidocaine over it. You can use a vasoconstrictor, obviously, beforehand if you're going to approach the patient through the nose. But what I'll do is I'll place a endotracheal tube to about 14 to 16 centimeters, and that serves two purposes. One is it essentially is a conduit for easy delivery of the scope, and secondly, it protects the scope from secretions and blood in the airway. And I've used it with some very dirty airways successfully with this approach. Now, again, to talk about KFC, so ketamine facilitated cooperation. It's something that, again, many of us are feeling very comfortable with, and Scott's work on his DSI approach, again, which is another way of defining ketamine facilitated cooperation. The procedure in his series was oxygenation. The procedure here is to facilitate topicalization, not to facilitate the intubation. Right, so you might have to use ketamine a little bit to help facilitate topicalization, or to facilitate the intubation by whatever technique. But it's not meant to be a substitute for appropriate topicalization. That's the clear distinction. So how much would you use in this situation? Again, that's a subject matter for a different post, but ultimately end up using upwards of 1 milligram per kilogram. I don't bolus that. I'll titrate it to effect. Recognize the fact that ketamine has 3 dosage ranges. One is an analgesic range. The second one is when you get into trouble, which is the recreational dose, which is somewhat between the analgesic dose and the dissociative dose, which is between 0.25 milligrams per kilogram and 0.75 milligrams per kilogram as a rough range. Sometimes you can have a non-cooperative patient in that range. So just be aware of that. But I don't routinely use ketamine. I use it if I need to do it. But I think we need to get over the fact that, that the uncooperative patient is an excuse not to do an awake. And I'll use a couple examples. The slide that I show at this stage is the slide of me doing an awake on somebody who had a penetrating neck injury, self-inflicted stab to the anterior neck into the airway, and had a bloody scenario. Again, was approached awake using an A-scope through the mouth and done successfully. I've used it in that gunshot wound to the face where the patient had filleted their tongue with the bullet fragments. Again, in that situation, I used a nasal approach where I placed the tube to about 14 to 16 centimeters, and I used it to protect the scope and help deliver it to the glottic inlet. Another thing that people are concerned about in doing an awake is time. Most situations we have time to do an awake, and this slide I did video this case, and if you look from start to finish, from topicalization to end tidal CO2 confirmation, the whole thing takes about 13 minutes to do. And this is consistent with other literature out there, is to do an awake approach, to properly topicalize the patient and complete the procedure anywhere from 10 to 15 minutes to do so. So it's not something that's done quickly. You're not going to do it in a crash airway, but most patients, I think you do have the time to do it. Now, a few things about position. The preferred approach depends on what device you're going to use. But most patients who have upper airway pathology or who are hypoxemic, again, they want to be sitting upright. So keep them in that position. You want to drop the bed, so you have the bed low, but the patient's sitting at greater than 45 degrees. Now, if you're going to use a direct laryngoscopy approach or a video laryngoscopy approach, which are both appropriate to do, the method that we suggest doing is the provider being actually on a stool to the left of the patient, and what they're going to do is manipulate the laryngoscope with their left hand as per usual, with the right arm sort of straddling around the head to help guide the laryngoscope in place. And I'll talk about that in a minute. It's called precision laryngoscopy, and ultimately place the endotracheal tube. People talk about a tomahawk approach where they're doing it from the front. I really don't recommend doing this for logistic reasons and from technical reasons. You're going to be using your right hand with the scope. So normally you're using the left hand, but if you use a tomahawk approach, you're going to be using the right hand. And then you're going to be using the left hand, therefore, to deliver the endotracheal tube. And I just don't think you're going to have the appropriate fine motor skills to do it. I can't speak from experience here. I know there's a lot of images out there of people doing them on mannequins. Maybe it'll work there, but I'm not sure how effective that's going to be on a real patient. Now, this is key. This is what we call precision laryngoscopy. And what precision laryngoscopy is this, is that when you put your scope in the mouth, what you have to do is you have to avoid application of pressure to the tongue. Now, I know you've topicalized it, but still, this pressure can still be uncomfortable to the patient. So you need to be looking in the mouth. And let's talk initially here about using a video laryngoscope or a direct laryngoscope. So left hand is guiding the scope in. The right hand, which is reaching around, is guiding the blade in the mouth. You're looking in the mouth, you're guiding the blade tip in, and you're applying no pressure on the tongue until the tip of the laryngoscope starts to disappear posteriorly around the tongue. At that point, you apply gentle pressure, looking for the epiglottis, so doing epiglottoscopy. And you're going to avoid that initial pressure on the tongue that's going to lose buy-in for that patient. There's a video here of Ian Morris doing an awake direct laryngoscopy on Adam Law, and what you see here is him again guiding the laryngoscope blade in with his thumb and his index finger of his right hand until the blade tip disappears, and then applying gentle pressure, looking for the epiglottis, and then gradually placing it into the vallecula and doing a lift to get a view of the larynx. That's what precision laryngoscopy is, whether you're using direct or video laryngoscope. Now, I think the ideal device to use if you're going to use a laryngoscope is to use a Macintosh configuration video laryngoscope, such as a CMAC. The reason being is that with a hyperacute angled blade, again, you'll get a great view, but managing the tube around the corner in this position with a patient sitting up can be a bit of a challenge. So using a Macintosh configuration video laryngoscope is the way to go. Now, some people will question, why would a Macintosh video laryngoscope offer an advantage over a direct laryngoscope? I think there's multiple reasons. One is that it's bigger. Your screen image is bigger than what you'd be looking at if you were looking through the mouth. And bigger is better in this situation, no question about it. There's no what I call framing distraction. Now, when you're looking in the mouth, doing direct laryngoscopy, there's all kinds of things in your way. You're looking, there's the blade there, there's the patient's lip, their facial hair, there's the mucosa, and then ultimately there's your target, the airway, as opposed to video laryngoscope, using a Macintosh video laryngoscope, you just have the area of interest there on the screen. The other thing is most video laryngoscopes, the view on the screen is a little bit better than the view in the mouth, right? So you're going to have anywhere from a 5 to probably a 30% better view depending on the device that you're using. And ultimately, this is the key thing, is that your endotracheal tube delivery is going to be easier with a Macintosh video laryngoscope than it is going to be with a hyperacute angle blade. If you are going to use a hyperacute angle blade, just a quick notice about that. Don't be too close. Again, there's this false sense of security that the more you see on the screen, the better it's going to be in terms of intubation. This isn't the fact. This has been shown scientifically. We've done a study here where we did a deliberate restricted view versus a full view of the glottic inlet using the glide scope, and the restricted view had a higher success rate. And we've all been in this situation where there's an access challenge or an advancement challenge with an endotracheal tube when we're using a hyperacute angled video laryngoscope. So again, what you want to do is you don't want to have that full view of the glottic inlet where you're looking at the cords, but when you look through the cords, what you're seeing is the anterior wall of the trachea. You might see the cricoid ring there, or even the tracheal rings there. That's a scenario where you're going to have a challenge in terms of placing the tube. You want to have more of a restrictive view. We call it sort of a 50-50 view, where at least when you're using the glide scope, the epiglottis is in view. It's hugging the top of your video laryngoscope screen, and you have a pogo of about 40% or less, and the glottic inlet occupies just the top 50% of the screen. That's the preferred approach or view when using a glide scope. That prevents over rotation of the blade and allows for easier tube delivery. So when you use this approach of a restrictive view versus having a full view. So that applies whether you're doing it as part of an RSI, but also doing it as part of an awake approach. Now, what do I use? I'm a big believer of using a flexible scope. A bit about terminology, a bit of a pet peeve. We're not using a bronchoscope. I'm not doing bronchoscopy. I'm using it for intubation. And it's not a fiber optic device anymore. It's a video device. So the preferred terminology for me is a flexible intubating endoscope. And the game changer for me has been the A-scope. If you have a reusable device, then all the power to you. The issue and challenges is maintenance and cost of that device. But the A-scope is a great device. Comes in 3 sizes: a slim or pediatric version, the standard adult one, and now it comes in a larger size, which is the one that we're going to go with, because it has a larger suction channel. And this allows us to manage secretions more effectively. I don't have experience yet with it, but I think it's a promising one, and it's the one that we're going to use. I've been using the standard one. Occasionally, in special circumstances, I'll use the pediatric one if the pathology dictates such. Again, it's a great device. You can record video on it, and if you want to watch me on YouTube, I've got a couple posts out there of not only me, looking at my larynx, but actually passing an endotracheal tube and going through the topical approach to the airway. Now, just to finish off with, as I said, we can gain more experience in doing the awake approach on the physiologically difficult airway and the patient who's not going to tolerate apnea. And that makes up a fair number of our patients in the emergency department. We gain experience here. I'm not suggesting that's where you learn it, but we gain experience here, so then we can use this approach with a higher likelihood of success when it's an anatomically or pathologically difficult airway. In terms of learning the skill, again, there's no shortcut. You have to practice, and I don't think it's mechanically that challenging. I really don't. It's about getting some fidelity with your right hand on the scope to maneuver it. It's really about moving your thumb and moving your wrist and keeping the rest of your arm stable, but just getting practice. And you got to get that practice on the usual suspects, meaning mannequins, and how do you transition to doing it on real patients? Well, I think one of the ways is to do it on each other. And as I've said, I've done this a lot on myself and had other people do it on me. But what we do as a group with our residents is we do, an awake laryngoscopy day where, they topicalize each other, and they get a sense of what the approach is, how they're going to hold the device, whether it be a video a laryngoscope or a flexible scope, and at least get a look at the airway. And as I said, perfect the approach to applying topicalization, because that's going to be your key to success. So that's my take on awake intubation in the emergency department. At the end of the day, when you sink the tube and you get your positive end tidal CO2, you got to be immediately prepared to sedate your patient and have your drugs available and do so. So the challenge is that I'm going to put out there is let's do more awakes. Let's talk about it more in the emergency medicine and critical care environment. I think it's a great approach for us to do. It should be part of our armamentarium in managing the difficult airway. I hope you've found this useful. Take care.